Welcome to Sirens Stethoscopes. Today we're deciding who gets blood, so let's get into it. Welcome back. I'm your host, Kevin. Today we're talking about patients who may or may not need blood and some things we put into that decision.
Yep.
So today I'm joined by Travis Goodloe. Thanks for joining us. Dr. Goodloe, why don't you tell us a little about you and who's Travis?
Sure, exactly. Well, in the short term, I'm currently serving as one of your assistant medical directors along with Dr. Stevens. I'm one of the EMS fellows at UT Health here in Houston. So clinically, I work at Memorial Hermann Texas Medical Center. I also work at LBJ Hospital, part of Harris Health. And then I also spend time working with HFD as part of their medical direction in addition to Sugar Land. It's been a good experience being out here with Sugar Land the last couple months.
Thanks. Yeah, we've enjoyed having you out here. So this is exciting, and welcome to the creating a bit of a lasting legacy that, sadly to say, the fellowship will come to an end. And we will not get to enjoy your company as much as we have.
Yes.
Or, at all, because you're leaving Texas.
A little bittersweet, but yes, moving back to Alabama here in a couple of weeks, hoping to take what I've learned here during my fellowship year and bring it back to the great state of Alabama, where we are in dire need of some quality medical direction and really in some need of some upgrades and improvements to our state EMS system there.
Excellent. Well, we'll be watching from a distance to see all the good things you're going to do. So today, like we talked about, I'm excited to discuss these cases, and we picked out some good ones because there's some really good discussion points. And like we've had in our previous discussions, that the obvious blood candidates are just that. If there's not a lot of question to it, we're looking at some people that we have a little bit of a pause. And are they really? Do they? Yep. And some of the things that will say, yes, they do, and some things that may be missing out of that.
Sure.
So, all right, so let's not waste time. Let's dive right in.
Let's do it.
All right, so case number one that we're looking at here is a 37-year-old male involved in a motor vehicle accident. And a quick description of this is some extremity injuries, right arm, right leg, that needed some splinting.
Yep.
And on initial presentation, we have a little bit of a reduced GCS.
Yep.
Our blood pressure is low. Our heart rate is relatively there. And just to give an overall picture of this, the best set of vital signs we have, the best,
yes,
is a blood pressure of 95/68, a heart rate of 114, a respiratory rate of 16, and an end tidal, talk about end tidal, I love end tidal,
yep, we'll get there,
29. So some of the big push that we've gone for here in Sugar Land is that we really need just two big things for giving somebody blood.
Yep.
We need an indication that you're bleeding.
Sure.
And we need some instability.
Correct.
So let's spoiler alert, this guy's got some bleeding. We get there, we have these injuries, we needed to do some means to control bleeding. He's lost blood.
Yep.
So let's dive into the instability side, because that's a little bit more of a less of a yes or no.
For sure.
Thing. Let's talk about this. Blood pressure, heart rate, end tidal. Tell me what you're thinking as you evaluate those numbers.
For sure. So I'm seeing someone who's obviously hypotensive. Our best blood pressures, sub 100 systolic, immediately concerning. Pretty much all of our pulse rates are greater than 100. They're in the 110 to 120 range. But one thing I want to point out with that is this guy's 37 years old. He's probably, presumably pretty healthy, presumably young enough that he can mount a pretty good response to his degree of hemorrhagic shock that he's experiencing here. So maybe not quite as tachycardic as you would expect for that degree of hypotension, but still concerning. And what really stands out to me that we haven't quite mentioned yet is this GCS. Documented GCS of 11 or 12, somewhere in that range. Clearly this patient's not perfusing their brain, not getting adequate oxygen flow. And for that reason, it's, indicative to me that we are in a hypovolemic state.
Yeah. I'm going to take a second to point out end tidal again. Yep. I love end tidal, our real-time evaluation of perfusion, which in a hypovolemic state, I'm going to presume that the volume problem is what's inhibiting good perfusion in the eliminating waste. That 29 in itself, really, I guess if we look at all of these, that the blood pressure is a little bit lower, but a heart rate of 114 isn't alarm bells terrifying.
Sure. Correct.
An end tidal of 29 isn't alarm bells terrifying.
No.
But we start putting the pieces together.
Correct.
And now we are. That you get under 30 is pretty indicative of something.
Yeah.
Like it's not usually 20 is the hard and fast. If under 20 is a shock state, I'm going to encourage you to look at 25. Let's be a little bit more sensitive. that I can breathe really fast and I can get my end tidal down,
Correct.
but not typically into the mid-20s.
Sure.
That the body's going to shut down, take over, and
Yep.
and regulate itself. So if we're looking at this 29, we're down into 26, 22. 29 is the best, by the way.
Yep.
So earlier on in this interaction, we have an end tidal of 23, 22. We should really be concerned about the
Definitely.
problem that's telling us.
Yep.
We see the blood pressure. We see the heart rate trying to compensate, right? So all these things go together. And this is a really good case to talk about. Shock index is another one. If we didn't have
Absolutely.
enough things saying to be concerned, right, shock index is our heart rate divided by the systolic blood pressure. We want more blood pressure than heart rate.
Exactly.
For those who aren't the math people, we want more heart rate or more blood pressure than heart rate. And right now we have more heart rate than we have blood pressure. Our shock index comes out to be a 1.2 at best.
Yep.
We are well over this threshold of being in a shock state
Definitely.
and heading towards increased mortality.
Correct.
These things. So,
And back to that end tidal, one thing to kind of just point out is, as you're bleeding, you're losing volume. Your body's not receiving oxygen throughout all of its tissues. It's getting acidotic. Literally minute by minute that goes by, you're getting more and more acidotic. So your body's response to that is to breathe faster, blow that CO2 off. So when you start to put all these puzzle pieces together like we referred to, you're building a case for someone who is pretty unstable.
yeah. Blood candidate?
I think so.
I would agree. Let's make a quick point, especially because, we love end tidal so much. We give this person a unit of blood, better volume expansion going on, better oxygen delivery,
Yep.
Better enhanced aerobic metabolism at the cellular level.
Exactly.
Not only are we going to see this end tidal get back towards a normal range, it's not outrageous to see it be a little bit high for a while
Yep.
as we start to catch up with the waste product that's accumulated.
Exactly.
So we could enter into a whole lot of discussions with permissive hypotension as well, that we don't necessarily want this guy's blood pressure to be 120 systolic.
Yeah, doesn't have to be.
That's another discussion of it. But improvement is not only blood pressure.
Yeah.
That if we hold this blood pressure, but a heart rate comes down, that's improvement.
That's improvement.
Hopefully we don't come down to the 40s, not
Yeah.
improvement. But we come down towards 100,
Sure.
in the high 90s, that's improvement.
Yeah.
End tidal comes up, that's improvement.
Yep.
This guy's oxygenating really well, according to the machine, which is great. But if we have somebody who's struggling to oxygenate because we don't have any volume to perfuse the cells, oxygen gets better. That's
It's in volume via blood.
so don't be focused in on any one given thing to tell you the problem or tell you the improvement.
Yeah.
And, should go without saying, though, the thing that tells you what the problem is, that's what you should continue to look at for the improvement.
Correct. Yep, exactly. So the parameters that tipped you off to say this patient's unstable, this patient needs resuscitation, specifically with blood in this case, now that we have it, those are the same parameters that you want to see get better. Which should prompt you to continue to reassess your patient if you are continuing to have a decompensation of those of those vital signs. That's going to prompt you to say, why is this patient not responding to blood? Is there an injury I'm missing? And so that should be your cue to reassess your patient.
Fantastic. So this is a good one. We have obvious bleeding that we can see. We experienced it, and we have some pretty substantial indications of instability.
Yep.
We give this guy blood.
Yep.
All right. Beautiful. Number 2. They get a little trickier after this.
They do.
That was the warm-up.
That's
guys.
right. That was our trauma case.
All right, so number 2, we're looking at, this is an older man, 70-year-old male in a facility. They called us because he's just not acting right. And there's some vague language. The dispatch notes has a little bit of it. Some of the staff there isn't exactly clear on it, but there may or may not have been some bleeding yesterday. We can't really figure out what kind of bleeding. We didn't witness bleeding. We're not experiencing it currently. We're not controlling it. But let's talk about this initial presentation. It is a GCS of 9.
Yep.
And a blood pressure of 48/33.
Thriving.
Thriving. Respiratory rate's 32. Oxygen's low 90s. Heart rate hanging out at 79, 80
Yeah.
in there. Let's take a look at history, and we do see that here we do have a pile of medications. We have some medications to rate control in there. All these things. At best, let's pick at our best set of vitals is a blood pressure of 81/40.
Okay.
Heart rate's still 70, but our respiratory rate is still 28. We have an oxygenation of 75%, and our end tidal is 12, still with that GCS of 9.
Yep.
Stable, unstable.
Incredibly unstable.
I think
this patient is probably not far away from coding at this point.
that's what I like to say. That's our next step. Our next step is, don't worry, sir. We put this machine on everybody. This board goes behind everyone. This is a sick person. And here's the tricky part. So we have instability, but we don't have bleeding. And this would be a different story if they were throwing up blood.
Sure.
If there was, this was a bedbound patient with an adult diaper and there was bloody stool in the diaper.
Sure. A big bleeding wound.
A wound, and
Epistaxis.
Yeah.
Things of that nature.
No indication of bleeding. Again, we have this squirrely story about maybe kind of bleeding yesterday, sort of. There's not a lot of description on, did we find wounds that were bandaged up?
Sure.
This would be a really good case to find out why. Maybe there is or isn't bleeding.
Yep.
We know this patient's pretty close to coding.
Yep.
And we've got to ask why one way or another, whether they get blood or not. We've got to find out what's the deal.
Yeah.
Right? So what are your thoughts as medical direction? I give you a call and say, Dr. Goodloe, I got this really sick person. They look like garbage. We can all agree that they're hemodynamically compromised. And the staff was talking about something about bleeding yesterday.
Yeah.
Give me some direction and guidance.
Sure. I mean, obviously, in a perfect world, you'd want some better history to delineate what was this bleeding that you saw, but we all know how this case goes, especially at a lot of facilities where you might be told that, I don't know, I just floated to this patient. I'm usually on a different floor. I don't know. So in this case, when you have someone who has a potentially reported source of bleeding, someone who is clinically unstable as this patient, this is a great option of a medical patient to empirically give blood to. Do we know exactly what's bleeding? Do we know exactly what we might be treating? We don't, but we're not going to know that. And we may not have the ability and the time frame that we're with the patient to figure that out. But we have very unstable vitals that, based on what we're seeing, we know would benefit from increased resuscitation, increased oxygenation throughout the body, and we can achieve that by giving blood.
Yeah. And, right, we don't have the diagnosis. We're not going to pull hemoglobin.
Yeah.
Right? Like, there's not an approved meter for the field anymore.
Sure.
So we're going to pull that stuff. Interestingly enough, because it's hindsight and we get to look back, this patient got some fluid and got some pressors and did not improve, which retrospectively to me says that yes, blood would actually probably be a very good play in here, that if this was a septic case, this was some other type of compromise, fluid and pressors would have produced some type of change.
Exactly.
Some type of improvement. So that's kind of my presumption.
Yeah.
I don't know if you agree with that one or not.
No, I do. And two more things I want to point out that are subtle, but that you might be able to pick up on if you're able to get history, whether it's from the patient or from a bystander on the scene, from nursing home records, whatever the case may be. You have a patient who has a documented history of anemia. So we know for whatever reason, this patient already has low blood counts. That might be anemia of chronic disease where this patient lives at a low hemoglobin because of the burden of underlying medical conditions. So the amount of stress it might take that patient to tip over the edge is already lower. You have someone who's also ESRD, end-stage renal. These patients are chronically anemic for that reason. There's a enzyme called erythropoietin. It's excreted and put out into our body through our kidneys. That signals our bone marrow and our bones to make red blood cells. If you don't have adequate erythropoietin because you have end-stage renal, that's why so many of these dialysis patients are baseline anemic. So it just takes so little for these people to kind of fall off the cliff.
Very interesting to look at, right? And I think we see that with very poor oxygenation, poor return on end tidal, that we got nothing to carry it.
Nope.
That is phenomenal stuff. I'm going to take with me with the anemia and the renal disease. That's okay. Excellent. So any other comments here? This is a fantastic gray area one.
Yes.
This is why you'll see in our guidelines of contacting medical control as an indication for giving blood. This is a phenomenal one of sure, it doesn't fit exactly in the box.
I don't have a for sure source of bleeding.
Yeah.
But you have an incredibly unstable patient that has a lot of indications that are pointing towards the fact that this patient's going to benefit from blood resuscitation.
And this is what we call clinical judgment.
That's right.
Welcome to it. Right? We can't script for everything under the sun. We need to educate. We need to be informed. We need to know how to take the information in.
Yep, and make a clinical decision. It's not going to be perfect every time. That's why we're having this conversation. Talk through these cases.
Absolutely. And you're right that maybe this patient doesn't need blood based on the information we have.
Yep.
But there's a good amount of information saying they might benefit from this.
I agree.
So we'll go for it. Okay.
All right.
Excellent. Number 2. Here we go. Number 3. We have a 75-year-old female. She is at home. She is not feeling very well. Weakness. Family can't get her to respond like they normally would. Let's see. Let's pick out her initial set of vitals here. Is a blood pressure of 95/58.
Yep.
Her heart rate is 74.
Yep.
Respiratory rate's not alarming at 14. Oxygenating. And a little bit later on, we get an end title that's in the teens, 17. I will give you the tip that she's on metoprolol. She's on a rate-controlling medication.
Exactly. So a beta blocker.
So let's talk about this presentation. I'm sorry, reduced GCS also.
Yep. In fact, in that 10 to 12 range, similar to some of our previous patients.
Right. So let's talk about this presentation. Mom just isn't feeling. I just can't wake her up very well this morning. Dr. Goodloe, help my mother, please. What are you thinking?
Story as old as time.
Yeah.
Old as time. Well, a lot of things come to mind. Why is mom unresponsive? Is she having a CVA of some sort, a stroke, a neurological event? Is that why she's unresponsive? Is she septic? Is she febrile? Is she decompensated for that reason in terms of a low blood pressure, low perfusion state? Has she been bleeding in some way? GI bleed, other source of bleeding? Really broad differential when you first see this patient. Is this a heart failure exacerbation? Is her heart not contracting well enough to produce enough forward flow in her heart that she's in a low perfusion state as a result? There's a lot of factors here. So history from family on scene becomes important to help kind of tease that out. Assessment of vital signs. Those are some, the key place to start, just like with any patient.
Excellent. I'm going to point out here that we hit a few of these good indicators that are listed in our blood administration guideline for being our instability numbers. We hit them. Absolutely we do. What's the big piece we're missing, though?
Let's see here. History of bleeding. We don't have it. We don't know.
We don't know.
We don't know.
And we don't have an indication.
Yeah.
This person's history is concerning history with stuff, but none of it is GI problems. None of it is some varices.
Yeah. It's CHF, diabetes, and hypertension.
Right. So
the standard triad.
You're right. So like you said, are we dealing with an existing problem that has just gotten worse? Is this a new problem?
Yep.
We have an unstable patient. We don't have an indication for bleeding. So would you say blood for this patient?
This patient's probably going to be a no.
Okay.
There's a couple of reasons I'm leaning against that. So we don't have a great history. We're not really sure if there's a cause of bleeding that would prompt us to go in that direction. Another key thing to point out, and this often gets glossed over, and sometimes it's just, based on this individual scene, all scenes are different, but in this case, we had time to get a pretty significant medication list. This patient's on metoprolol, so a beta-blocking, rate-blocking agent, as we've already described. That's going to blunt this patient's ability to mount a tachycardic response to her degree of hypotension. So, a couple of sets of vitals into the case here. We have a blood pressure of 68/42 with a heart rate of 41. So that's pretty concerning. Is this patient bradycardic because they can't mount a response? Is this patient becoming bradycardic because they are in such a low flow state that we're getting close to this patient arresting? It's kind of a little bit difficult to know.
Or is this person in a low flow state bradycardic because of the low flow state?
Correct.
Or is the low flow state because they're bradycardic?
Yeah, chicken or the egg.
Oh, man. Okay. Come on. Great point to emphasize that just because this person isn't a good candidate for blood, they are still a great candidate for therapy and interventions.
Absolutely.
Yes, please. Otherwise, this is going to become another CPR case.
That's right.
Right?
Yep.
And again, looking at it retrospectively, hindsight's 20/20.
Every time.
This patient responded pretty nicely to some fluid and suppressors.
They did.
And we get to the hospital with an improved blood pressure up there with a 120 systolic pressure. Heart rate doesn't change. Surprise, surprise.
But 74 improved.
It is
might be improved from where we were.
We are out of the 40s, that's for sure. Our end title gets a little bit better. So this, again, kind of retrospectively kind of gets to confirm that, no, a lack of blood wasn't the problem for this patient. There was a lack of some other things. And, like you mentioned with this medication list, maybe a lack of stimulation of the heart.
Exactly.
Is what we're dealing with.
Yeah. Maybe a mixed case here of maybe some sepsis, maybe some cardiogenic shock, maybe a mixed shock state here.
Yeah.
But I don't suspect in this case that we're dealing with a hypovolemic shock case.
Yeah. So we picked this case specifically to emphasize just that, that blood loss, this hypovolemia is getting an awful lot of attention as we prepare to administer and transfuse blood, rightfully so.
Yep.
But let's not get tunnel visioned in on just that. Let's not forget about what sepsis does, what anaphylaxis does. Heck, what obstructive shock will do as we get these trauma patients as well.
For sure.
Just because we have a trauma patient with a low blood pressure does not mean they're automatically a blood candidate.
Yeah.
Maybe there's other things we need to pay attention to.
Yeah.
And we can correct those too.
And one thing I want to bring in on this, specific here to Sugar Land Fire is we're lucky that we have pre-hospital focus. We have it on Ops 1. All the captains or whoever might be riding up that day on Ops 1 is going to have access to an ultrasound. This is a great candidate to get Ops 1 on scene, even if they're not initially dispatched. Have them come to the scene, have them help, do a bedside ultrasound and figure out what's going on. Are we seeing good, robust squeeze and maybe there's just a problem with filling that tank? Are we seeing really poor cardiac output, maybe indicating this is a CHF exacerbation? What are we seeing on the IVC? Is it super dilated, indicating that this patient's having decreased forward flow of the blood and it's pooling back in the IVC? What are we dealing with here? That can give you a lot of information on this case. So we have a lot of resources at this point, largely thanks to you over the last couple of weeks to years.
Not me.
So this is a great case to utilize those.
I appreciate that kind of plug, right? Let's continue to work the problem.
Yep.
I'm a space nerd, right? So Gene Kranz tells us to work the problem. Don't make things worse by guessing.
Yep.
In fact, I just wrote it on my board this morning. I don't know why, because I was thinking of it. But you're right. This is a phenomenal case that this is where we get to be clinical practitioners.
Exactly.
We get to be real providers and dig in, get those answers, and not land at the right care because we guessed it enough of them.
Exactly.
And it was accuracy by volume. We picked the right one.
Exactly.
Deliberately.
Correct. Because this could be that patient that if you just slam them with a liter or two of fluid, that patient who's right on the edge of crashing can easily tip into that state easily.
Especially if we're talking about these bleeding patients.
Yep.
I mean, we talk plenty about how saline is not a great choice for people who are going into coagulopathy.
Exactly.
So let's find out what we're dealing with and let's address it the right way.
Yep.
Well, Dr. Goodloe, I appreciate your insight on these cases.
No problem.
Your feedback on them. Any other things that you didn't get to say about pre-hospital blood, about determining the right people for it, or just some of the challenges in making decisions of who does and doesn't get it?
Sure. I think some general comments would be, this is a really, really clinical decision. Sometimes we're going to give blood to people who maybe don't really need blood. And then there's going to be cases where maybe we don't give blood to people we maybe should have, because there's going to be a lot of gray zone. We're going to have that trauma patient where it's the obvious case, like we talked about. We're going to have the GI bleed medical patient where it's the obvious case on the other end of the spectrum. There's going to be a lot of gray highlighted by these two last cases we talked about. What I would encourage to those who are out in the field is make a clinical decision based on the information that you're able to obtain. Stand by it. If you don't give blood, have a reason for why you didn't. If you did give blood, have a reason for why you did. That creates a lot of learning in the future, and we can help tease this out better. That'll help everybody learn and help us be more accurate with our blood administration over time.
Phenomenal. I had a lot of fun discussing these.
Yeah.
I always have fun having conversations with you. That's
I
why
know.
I asked you to come do this. So I really appreciate your time. Thank you.
Absolutely.
And,
Happy to do it.
I know I'll get to see you a little bit more, but I wish you well in the future, and we all do. We've enjoyed having our time with you.
I appreciate it. I've had a great time being out here at Sugar Land. It really has been a really worthwhile experience. I've learned a lot. You've got a lot of really good things going on in this agency. You are more progressive than you probably think you are. So embrace that and know that you're doing awesome things.
Well, thank you, and thanks for your contributions to that as well.
Absolutely.
So thanks for listening in, and we will catch you next time.